Bismillahirrahmanirrahim. Today we are going to start the chapter Disorders of the Nervous System. First of all, we have to look at the normal structure. If we look at our head, basically the skull, we have a hard covering known as the skull cap. Then there are three layers. The first layer is your dura mater, then arachnoid matter, and then pia mater. Between these three layers, we have got three spaces. We've got epidural space, that is between the skull and the dura mater. Then we've got the subdural space, which is between dura mater and arachnoid mater. And then we've got subarachnoid space, which is between arachnoid matter and pia mater. Please make this concept clear so that we can understand the different pathologies, because different pathologies, they affect different parts of the brain during their course. First of all, we are going to look at meningitis. Meningitis simply means inflammation of the pia mater, arachnoid matter, and the space between it, which is the subarachnoid space. It is of three types: acute bacterial meningitis, acute viral meningitis, and chronic meningitis. First of all, we're going to look at acute bacterial meningitis. The route of spread of acute bacterial meningitis is of three types. The most common is the blood, and the different modes through which it reaches different systems is the respiratory tract and the skin. You can see different organisms predominantly choose a special system which they infect, or it is their favorite mode of action when they are trying to enter the host. In the respiratory system, Neisseria, H. influenzae, and Streptococcus pneumoniae are the dominant bacteria. Where skin is concerned, there are special bacteria which specifically cause neonatal meningitis. They are the organisms which we must consider. Now, if we look at the direct implantation, this is another route through which the bacteria are directly incorporated into the brain. And this occurs if there is a skull fracture or there is brain surgery. And in both these conditions, the brain can be directly exposed to the external environment. The third route of spread is the local spread, where adjacent areas are infected and ultimately the infection travels towards the brain. The most common sites are middle ear infections and infections of the paranasal sinuses. Both of these regions have direct connection to the brain. Now, as we go towards the pathology, let us look at its gross appearance. Please remember, it is an inflammation. All the signs and symptoms of inflammation are going to be evident here. The meninges, they are going to be congested and opaque. The opacity comes from the purulent exudate that is collected between the subarachnoid space. The brain, the spinal cord, both are going to be congested and edematous due to the inflammation. If we look microscopically, what you are going to find is congestion, neutrophils, and fibrin. Neutrophils are going to be there because neutrophils are the dominant feature where acute inflammations are concerned. As we go towards the clinical features, let us consider that basically there are three major groups, which you can call them, which are concerned with the signs and symptoms which are associated with a pathology of the nervous system. First of all, there is the general group, in which general features of infection are there, like fever, rigor, chills, weakness, malaise. Then the other group is, which is due to the raised intracranial pressure. The signs and symptoms which are associated with increased intracranial pressure are headache, nausea, vomiting, papilloedema, deterioration of consciousness, and convulsions. The third group comprises of signs and symptoms which are caused due to meningeal irritation. Now this is neck rigidity, photophobia, and positive kerning sign. Please correct the spellings in your book. It is not kerning, it is kerning, Kernig. It has been misspelled in this book. Kindly correct the spellings. Kerning sign is if you flex your leg at the hip and you bend your knee at 90 degrees like that. Now, if you try to straighten your knee, a person with meningeal irritation will not be able to straighten his leg. This is due to the inflamed meninges, and these inflamed meninges are irritating the nerves which are supplying these muscles. So straightening of the leg is painful for a person who is suffering from meningitis. Now here investigations are very, very important because they form a very, very important diagnostic tool where diagnosis is concerned. We take the cerebrospinal fluid for this investigation, and for that a lumbar puncture is done. The findings are the pressure, the cerebrospinal pressure is going to be increased, markedly increased. The fluid which is obtained is going to be turbid or purulent in appearance because this is going to be an exudate. Thirdly, it is going to have a high protein content. Why? Because it's a bacterial infection and the fluid is, again, as I'm repeating again and again, it's an exudate. It is going to have very low glucose levels. The glucose levels are going to be below normal. Why? Because the bacteria utilize this glucose for their survival and for their multiplication. So they use up glucose which is present in a fluid. Then you are going to find neutrophils as they are the predominant cells in any acute inflammation. You will, if you stain this fluid, it is going to show you positive gram staining. And if you put this fluid on a culture plate, then you will get a positive bacterial culture. So these are very helpful diagnostic findings which help us to diagnose as to which bacteria has caused meningitis and which type of meningitis is it. Because again, we have to consider, apart from acute bacterial, we also have acute viral. So if we find bacteria, then we know it is acute bacterial meningitis. Treatment is, again, it is basically antibiotics and symptomatic treatment. Now we come to acute viral meningitis. The etiology is obviously viruses. The important ones are echovirus, mumps virus, Coxsackie virus. Now the signs and symptoms are exactly the same as acute bacterial meningitis. The same general features, the same signs and symptoms of meningeal irritation, the same signs and symptoms of increased intracranial pressure. But the signs and symptoms are going to be of a lesser intensity as compared to the acute bacterial meningitis. So the virus shows the same signs symptoms but in a much milder form. Now if we look at the investigations, what you are going to see is, again, the cerebrospinal fluid pressure is going to be increased, but not as much as seen in bacterial meningitis. This fluid is going to be clear because basically usually it is of transudate variety. Glucose levels are going to be normal because virus does not eat up the glucose in our fluids. Proteins might be slightly elevated or they may be normal. The predominant cells here are going to be lymphocytes and the viral cultures are going to be positive in 70% of cases. As viral diseases are self-limiting, only supportive treatment is given here. Now, if we come to chronic meningitis, chronic means something which is slowly developing over a period of time. And this is inflammation of the subarachnoid space that can last for months or even longer. If you look at the causes, you will see that the bacteria and the different other microorganisms which are involved here, they are relatively more stubborn organisms which have a notorious history of giving prolonged illnesses like Mycobacterium tuberculosis, Trichonema pallidum, different types of funguses, sarcoidosis, and certain cancers like leukemia, lymphomas, brain tumors, and chemotherapy drugs. Because when you give chemotherapy drugs, and these are usually injected in some cases directly in the subarachnoid space. So this can cause direct infection to that area. Now, if you look at the pathology, chronic the meningitis, which is caused due to chronic tuberculosis and fungal organisms, they are characterized by caseous granulomatous inflammations. Now we know that tuberculosis and in some cases fungi, uh, they the type of necrosis that they cause is of the caseous type. And as this is a chronic inflammation, and we know that tuberculosis and in some cases some fungal infections, this chronic inflammation is of the granulomatous type. This is exactly the scenario which is presented here. So you will find caseous granulomatous inflammation which has ultimately resulted in fibrosis. What happens after fibrosis is this fibrosis causes marked thickening of the meninges, which is the pathological feature where chronic meningitis is concerned. If you look at the exudate, it is abundant in quantity, and it is dense, and usually it settles at the base of the brain. The dominant cells here are going to be the lymphocytes and plasma cells, which are the dominant cells we see in any chronic inflammation. Now what happens is when this dense exudate with fibrosis, what it can do is it can form adhesions in this subarachnoid space. And when these adhesions are formed, what we get is obstructive hydrocephalus. What we mean by that is that the flow of the cerebrospinal fluid is blocked and the fluid starts accumulating there. Now, if we look at the clinical features, headache, stiff neck, and the other signs of meningeal irritation are there. But what we see is that sometimes in many cases, the classical meningeal signs are either absent or they are so mild or generalized that it becomes difficult to diagnose them. Now the diagnosis is basically done on, again, investigations where cerebrospinal fluid is taken through lumbar puncture. Here again, the pressure is going to be raised, protein content is going to be very high, glucose is going to be low, because this is chronic inflammation. And in chronic inflammation, the dominant cells are the lymphocytes. And you will, if obviously bacteria is involved, you will see low levels of glucose. Here the dominant cells are going to be lymphocytes, but sometimes some neutrophils may also be present. Acid-fast stains, they are rarely positive, and mycobacterium cultures, they are more reliable because we see more positivity where cultures are concerned as compared to acid-fast stain. But the thing is that these cultures, sometimes they take a very long time. So what we do is we do the PCR test, which is relatively faster, and we get results much quicker as compared to the culture incubation times. So CSF PCRs are sometimes involved to reach the diagnosis at the earliest possible time. Apart from that, CT scan and MRI of the brain, they also help. And depending on the etiology, the organism involved, if it's tuberculous, we give anti-tuberculous treatment. If there is some other treatment, we can give corticosteroids. So it depends on the microorganism what sort of treatment we are going to start. Now let's look at hydrocephalus. Hydrocephalus simply means accumulation of excessive amount of cerebrospinal fluid within the ventricular system of the brain. First, let me iterate what is the normal flow of the cerebrospinal fluid. Technically, 500 milligrams of CSF is produced daily. And at any given time during that day, our ventricular system has about 100 to 160 mils present in its different chambers. Now, what are the organs which are producing this fluid? Basically, it is the choroid plexus which are present in your four ventricles. Then the lining of these ventricles, they also produce CSF, and the lining surrounding the subarachnoid space, this also produces some CSF. Now, what is the route of flow? CSF, majority of the amount is formed in the two lateral ventricles. From there, they flow through the cerebral foramen into your third ventricle. From your third ventricle, they follow the cerebral aqueduct into the fourth ventricle. And your fourth ventricle has three small channels through which your cerebrospinal fluid drains into your subarachnoid space. And in your subarachnoid space, it is reabsorbed through the lymphatics and the venous sinuses which are present there. Now, this is the normal flow that we see. So what we are seeing is that cerebrospinal fluid is passing through the three ventricles, first lateral, then it falls into the third ventricle, then the fourth ventricle, and ultimately in the subarachnoid space. And from there, it is again reabsorbed by the lymphatics and the venous sinuses to be drained back into the circulation. Now we come to hydrocephalus. We have to see what is the mechanism which causes accumulation of cerebrospinal fluid within this ventricular system. Now, if we see basically what you are going to see in hydrocephalus, it is usually the obstruction which is causing the accumulation of cerebrospinal fluid. It is a very, very, very rare event where the quantity of CSF increases. In majority of the cases, the quantity of CSF does not increase. It just collects at a certain point due to some obstruction. This blockage can be due to conditions like spina bifida and birth defects. You see brain infections, you see meningitis, you see pus, you see hemorrhage. There can be a lot of different conditions which can lead to this. Now, keeping these in mind, let's see the different types of hydrocephalus that we are going to encounter. The first type is based on the anatomical classification. It can be of the non-communicative or obstructive type, or it can be of the communicating type. Now, in the non-communicating obstructive type, what happens is the obstruction is present within the ventricular system. The CSF is not able to pass from the ventricular system into the subarachnoid space. Now, this can be due to some tumor, some congenital defect, or some scarring which has resulted due to some previous inflammation. The communicative hydrocephalus is where your cerebrospinal fluid passes normally through the three ventricular systems, but there is some flow obstruction in the subarachnoid space. So reabsorption is reduced and the fluid starts accumulating there. This is the communication hydrocephalus because the communication of the ventricles till the subarachnoid space is normal. The problem is somewhere in the subarachnoid space. Now we come to the functional classification. There is the high pressure hydrocephalus and then there is the normal pressure hydrocephalus. In the high pressure hydrocephalus, the obstruction is, let me put it another way. If we look at a child and child whose sutures have not yet fused together. If there is some condition, if there is some obstruction due to which cerebrospinal fluid is being obstructed and hydrocephalus is occurring, the what you will see is that the baby's head will start enlarging. But as such, the intracranial pressure will not be raised in proportion to the amount of obstruction, because the sutures have not yet ossified together. The brain has the space to enlarge as fluid accumulates. If the sutures have fused together, then the brain does not have any space to uh, extend or expand. So what happens is there is increased in the intracranial pressure, and you will start seeing signs and symptoms of increased intracranial pressure. So this is known as high pressure hydrocephalus. Now the normal pressure hydrocephalus, again this is a misnomer. There is no such thing as normal pressure hydrocephalus, but then it's a name which has just kept up, it just keeps up coming, and it has not been changed. But there is no such thing as normal pressure hydrocephalus. It's a misleading term. This type of hydrocephalus is seen in older people, basically who are over 60 years of age. And this obstruction to the flow of the cerebrospinal fluid, gradually over a period of time, it develops slowly, and the person has time to adapt to this gradual accumulation of your cerebrospinal fluid. So there is very slow enlargement of the ventricles. That is why the sign symptoms are not so prominent. Gradually, the pressure increases, but the pressure increase is not as significant as seen in other cases. So the hydrocephalus is there, but the process is so slow, it is so slow and so gradual that this condition has been termed as normal pressure hydrocephalus. Although the pressure is not normal, it is raised, but the process is so slow that the person has time to adapt to this condition. We don't exactly know the etiology of this condition, but again, this is something which is seen in older people, and but the thing is, there is enough time for these people to adapt to this gradual accumulation of the cerebrospinal fluid. Now we come to a very important topic, which is known as CVA. In layman terms, sometimes we call it just stroke, but the medical terminology is stroke cerebrovascular accident, CVA, cerebral vascular accident. This is a focal neurological deficit. Usually this is a point of damage or a point of infarction which has been caused either due to cerebral infarction or due to cerebral hemorrhage. So this neurological defect can be due to infarction or it can be due to hemorrhage. Now let's see at ischemic stroke. That means a deficit which is caused due to cerebral infarction. If any of the major cerebral artery is occluded, it is going to cause cerebral infarction. The etiology, most common, it is atherosclerosis and thrombosis. When there is plaque formation in the cerebral arteries, what happens is not only the plaque narrows the lumen of these arteries, thrombus formation also starts developing over these plaques. And this thrombus then further obliterates the lumen of these arteries. The very common factors in which we see this atherosclerosis superimposed by thrombosis are hypertension, diabetes mellitus, hyperlipidemias, and smoking. Atherosclerosis, they affect usually the larger vessels like the internal carotids and the vertebrobasilar arteries. Now, another thing we have to consider are the emboli. Embolus is another factor which causes infarction. Now, emboli can originate from a variety of sites and reach the brain. Now, if we look at the emboli, the sites from where they can originate are mural thrombi. You must remember what are mural thrombi. These are thrombus which are formed in the heart and the arch of aorta. So when these thrombi embolize, they can go and get stuck and they can occlude the cerebral vessels. Then what we have studied earlier also, valvular vegetations, when they break as emboli, again they can go and affect the cerebral vessels. Prosthetic cardiac valves, again emboli can originate from these valves. Mitral stenosis and fibrillation, these are conditions which cause thrombosis, and from this thrombus emboli can break away and they can go into the systemic circulation and to your cerebral arteries. Then atherosclerotic diseases of the arch of aorta or the circle of Willis, again from here over these atherosclerotic plaques, not only pieces of these plaques can break away and form emboli, thrombus can form over these plaques, and then pieces of this thrombus can break away and form emboli. So emboli is another important factor which can cause infarction. Now, if we look at the pathologies, just remember now we are talking about the brain. And when necrosis is concerned, please remember what we read. The necrosis in this type is going to be of the liquefactive type. So whenever the blood supply of the brain is occluded, what is going to happen? You will see necrosis of the liquefactive type. So liquefactive necrosis is going to be seen. Now, cell death occurs within 2 to 3 minutes of the occlusion of the artery. Because these are very sensitive cells, they cannot exist for more than 3 to 4 minutes in the absence of oxygen. But the tissue changes, the changes in the tissue, you will start observing after 8 to 12 hours of the infarction. So for the first 8 to 12 hours, the tissue might look absolutely normal, but microscopically cell death has occurred. But the changes, they take about 8 to 12 hours to manifest, and after 8 to 12 hours we are able to appreciate the death changes which start in these tissues. After 8 to 12 hours, what you're going to see is softening of the bone, softening of the brain, and the normal architecture will be completely lost. And the inflammatory cells that you are going to see there are going to be neutrophils. After 48 to 72 hours, the infarct will be fully formed. It will be a pale soft area composed of liquefactive necrotic cells, and the surrounding brain tissue is going to be edematous. As days pass, macrophages are going to infiltrate this necrotic site, and then they are going to start phagocytosing this necrotic parenchyma. There is going to be extensive phagocytosis which will further lead to more liquefactive necrosis. Ultimately, in about 6 months, most of the infarcts have been cleared. But what happens is, when these infarcts have been cleared by these macrophages, what is left behind are cavitations. So we know very well brain tissue is permanent tissue. It cannot regenerate. So once the macrophages clean up the area, clean up all that debris, they clean up all that liquefactive material, what is left behind are cavitations in the brain. And depending which part of the brain is affected, the signs and symptoms are going to be according to that site of the brain which is involved. Now, if we look at the clinical features, there is sudden loss of neurological function corresponding to the area which is involved. And as the infarct advances, we will see how much damage has been done, and the amount of damage which has been done in the brain, that is going to be proportional to the supply area of that region in our body. Now, the branches of the middle cerebral artery, usually they are the most common vessels which are occluded and they cause infarction. Now, let's see the features of cerebral infarction due to occlusion of middle cerebral artery. Now, the middle cerebral artery supplies the lateral surface of the hemisphere, speech areas, and the optic radiation. Just keep it in mind, lateral, optic radiation, and the speech area here. So you will see contralateral hemiparesis, weakness of the opposite, loss of sensation of the opposite side, visual field abnormalities, and speech abnormalities. Now let's look at the features of the cerebral infarction due to occlusion of vestibulo-basilar artery. Now this supplies the cerebellum and the brainstem. So what you're going to see here is weakness and sensory loss of the opposite side of the body, cranial nerve paralysis of the same side, incoordination of movement, that is ataxia, and hypotonia. Before we go any further, let's see what is TIA. It is transient ischemic attack. Transient ischemic attack. Transient means temporary. This is a neurological defect which lasts from a few minutes to several hours. And usually the clinical significance of TIA is that it is seen that people who suffer from a TIA, 1/3 of these people, they suffer from a stroke within the next 5 years. So this is a warning sign which tells us that we should intervene, and we should definitely check up this patient as to what is happening and if we can prevent it. Usually the problem lies either there are atherosclerotic plaques, or there is some sort of an embolus, or there is some sort of a thrombus which is causing some sort of a dysfunction in the blood flow to the brain. If we can intervene in time, we can correct these problems, these pathologies, and we can prevent a stroke. But if we ignore this thing, then in 1/3 of the patients, they may suffer from stroke. The investigations, CT scan is the main modality which we use where we deal with CVA. Now let's look at hemorrhagic stroke, which is also known as intracranial hemorrhage. It can be of two types: spontaneous intracerebral hemorrhage and spontaneous subarachnoid hemorrhage. Let's look at spontaneous intracerebral hemorrhage. This is most commonly seen in adult life, and it accounts for 10% of the strokes that occur. Basically, the etiology of this stroke is hypertension. It has been seen that more than 80% of the cases where the stroke is concerned, the underlying pathology is hypertension. Now, if we look at the pathology of this disease, the most common hemorrhage site is around the basal ganglia and the internal capsule. And what happens is lenticulostriate arteries, they rupture. And hypertension is one of the main causes due to which this hemorrhage occurs. Now, what happens in hypertension is that the larger arteries show atherosclerotic changes, And the medium and smaller arteries and the arterioles, they show changes in their hyaline structure. So there is hyaline change in medium, small and small arteries and arterioles, and there are atherosclerotic changes in the larger arteries. Now this hyaline change, what it does is it weakens the artery at that point, and it makes it more susceptible to rupture and hemorrhage to occur. In chronic hypertension, a person may also develop small aneurysms. These aneurysms are known as Charcot-Bouchard aneurysms. And when there is hypertension, which means increased pressure in your blood vessels, aneurysms being weak areas in a vessel, they rupture and hemorrhage can occur. Now, once hemorrhage occurs, what happens is that blood escapes out of these blood vessels and it starts spreading into the brain tissue. And ultimately, this blood reaches the ventricles and your subarachnoid space. Once they reach your subarachnoid space, what happens? They start irritating the meninges. So you will start getting signs and symptoms of meningeal irritation. Now, on the other hand, as the blood is hemorrhaging out of the vessel and it is accumulating in the brain tissue, it is collecting there, and the brain does not have space to expand to accommodate this spillage of blood. So the pressure within the brain increases. So what you will now see also along with meningeal irritation are signs and symptoms of raised intracranial pressure. And when this pressure keeps on increasing and increasing, it pushes the brain downwards through the tentorial foramen onto the brainstem. This is known as herniation of the brain, and this leads to sudden death because the respiratory centers are totally compromised. The clinical features we have already discussed in the pathology. What you are going to see are signs and symptoms of raised intracranial pressure and those of meningeal irritation. Investigation, CT is the most ideal investigation because it can exactly locate where the hemorrhage is occurring. Now the other type is spontaneous subarachnoid hemorrhage. The etiology, what we have seen is berry aneurysms. These are congenital aneurysms and they are not evident at the time of the birth. They gradually develop over the years and they can be seen in adult life. But they are congenital because as the baby is born, these vessels, they have weaknesses in their walls. Basically, the weakness basically lies in the intimal walls of these aneurysms. And these aneurysms are usually seen in the circle of Willis. Again, being an aneurysm, these are potential points of weakness and they can easily rupture. But the significant thing is these are congenital anomalies which are not evident at the time of the birth, and gradually as time passes, this weakness develops and it shows as the person advances in years. And ultimately, they are seen as berry aneurysms. And when they rupture, they cause hemorrhage of the vessels. If you look at the pathology, it is commonly seen in adults. Hypertension and atherosclerosis, they play a very important role because hypertension, again, it increases the blood vessels pressure and it is easy for an aneurysm to burst. Similarly, atherosclerosis, they narrow the lumen of the vessels and Narrowing of the vessels again increases the pressure of the vessel, again leading to rupture of the aneurysms. Again, anything which increases the pressure in these blood vessels can cause rupture of this aneurysm, like extensive exercise or even sexual intercourse. Now, the clinical features are going to be exactly the same. The features that you will see the sign symptoms of raised intracranial pressures, and then you're going to see the sign symptoms of meningeal irritation. And the choice of the best choice for investigation is again CT scan. Now let's look at the different types of brain traumas. Now, brain trauma is injury to the brain. Now, this depends upon three things. Injury, what sort of an injury is? The things that we consider is what was the shape of the object which caused the injury? What was the force with which the object hit the head? And what was the movement that the head was undergoing when it was being hit by an object? Now, this becomes very important because if somebody comes with you and suddenly he raises a stick or something and tries to hit you over the head, you immediately swing your head towards the side to avoid it. So sometimes this movement, it can affect the severity of the disease, of the blow. If you are vigilant and you are able to escape the main impact, you can escape from a very severe injury. Now, the types can be epidural, subdural, or parenchymal injuries. Let's look at the epidural hematoma. Hematoma, you know, hematoma means accumulation of blood in tissues. Now, hematoma in epidural injuries is between skull and the dura mater. So, fluid collects in the epidural, blood collects in the epidural space. And this is usually due to the rupture of the middle meningeal artery. And as soon as this artery ruptures, there is immediate increase in the intracranial pressure, and you will start seeing the signs of raised intracranial pressure. And it becomes very dangerous because raised intracranial pressure can push the brain down the tentorial foramen and cause brain herniation, which can lead to immediate death. Then the subdural hematoma. This is collection of blood between the dura mater and the arachnoid mater in the subdural space. And this is usually caused by blunt force trauma where the skull bone is not fractured. And this hemorrhage occurs due to rupture of the bridging veins, the network of veins which connect the venous system of the brain with the venous sinuses, which are present in the duras. In this case, the symptoms gradually occur over a period of time, and patient may manifest like he may fluctuate between different levels of consciousness. So you have time to intervene in most cases, and that can sometimes save the life of the person. Then comes the parenchymal trauma. This is trauma directly to the brain tissue, and it can be grouped under concussion, laceration, traumatic intraparenchymal hemorrhages, and diffuse axonal injuries. Now, concussion is transient loss of consciousness. Transient means temporary, and this loss of consciousness is immediately after the trauma, and usually the trauma is by a blunt force. As soon as a blunt force is hit or applied to the head, immediately that person loses consciousness for some time. This is known as concussion. Next comes laceration. Laceration, in it there is a tear, a crude tear in your skull due to some penetrating injury. And due to this penetrating injury, what you will find is hemorrhage and necrosis. Next comes traumatic intraparenchymal parenchymal hemorrhages. These hemorrhages are contained within the brain. They do not extend or come out of the surface. And usually they are due to the direct rupture of the intracerebral vessels at the time of the trauma. Lastly, the brain injuries can be diffuse axonal injuries. Now, in this condition, usually, if you look grossly, the brain damage apparently doesn't look so severe, but there is severe neurological damage. So grossly, the brain tissue might not look that damaged. It might not look that the injury is so severe. But in these cases, the neurological damage, the neurological deficits, they are very, very severe. And if you look microscopically, what we see is the white matter is destroyed. So the axons, because axons, they have the white matter, the axons have ruptured due to the trauma and the white matter is destroyed. The complications of trauma, there can be a long list, but the most common traumas seen are brain edema, brain herniation, brain stem compression infections, hydrocephalus, and epilepsies. Now we come to encephalitis. Encephalitis, inflammation of the brain parenchyma. This can be of three types: viral, bacterial, and fungal. Now, viral, it is the most common type of encephalitis that you can encounter, and herpes simplex virus and arbovirus are one of the two main viruses which cause viral encephalitis. Histologically, if you look at the tissues, you're going to find mononuclear cell infiltrate, and this infection may be acute or it may be a slow chronic one. The other is bacterial encephalitis. Obviously, here the source of infection is going to be some bacteria, and usually it is due to some infection in the adjacent areas like the middle ear cavity or the paranasal sinuses, or there is some pre-existing meningeal infection which is there. Here you might also find acute cases, you might also find chronic cases. In chronic cases, again, tuberculosis is something which is pretty common in this scenario. And lastly comes the fungal encephalitis. Fungus is something which, whenever your immunity is compromised, fungal infections happen. So in patients who have cancer or who are immunosuppressed, fungal encephalitis is something which you can find in these cases. And Candida albicans, Histoplasma capsulatum, these are the most common fungi that you can find which can cause fungal encephalitis. Thank you very much. These were the lectures on disorders of the nervous system. And if you have any questions, please just leave them in the chat box, and then I'll answer them accordingly as they come.